Okay, the last part for week 1, I'm sure you are thrilled. There's quite a few chapters in this. They're really I put patient-centered medication management administration. Some of this material I know you have covered already in previous semester. There's just like general things to go over, so that's why I just compiled it together. So we'll start with chapter 9 and just a summary of all these chapters here. Medication administration in community setting. I don't know if you're going to get opportunities to do anything in the home health. Hopefully, I know they're working on changes so you can get some home health experience. You'll do some community-based things, maybe some things at the health department. I know you'll be in the school systems. So here, hints for patient safety, laboratory testing, therapeutic response, supplies. Over the counter, it's really no different than being in the hospital, other than you don't have as many resources with you. You teach people to be active. You need to learn things that are within your community, resources available, social services, support systems. Where do they bring their used insulin syringes? Is there a pharmacy nearby that's going to take unused medications? How do they need to discard them, not just flush them down the toilet? When you're talking about diets, possible drug-food interactions, tyramine-rich foods, that's for food-drug interactions, potassium-rich foods for people taking potassium-wasting diuretics such as furosemide and hydrochlorothiazide. The tyramine-rich foods, I'm always thinking of cheese. It's the aged cheeses such as Swiss Parmesan and blue cheese. Those are the first ones I think of. Certain meats that are treated with salt, like sausage, pepperoni, salami. Those are the biggest tyramine foods that I think of when you get to MAO inhibitors, which are usually a lot of psychotropic type of meds. Okay. Self-administration. Instruction should be given on all skills related to the drug regimen, how to store it, how to refill it, how to whether inject it, take it orally, how to know when you're taking the thing, if they're using an oral inhaler that has a steroid, rinsing their mouth afterwards. Do they need to shake it? Where do they need to store it? Is it nitroglycerin? It should not be in the sun, all those type of things. Side effects. Advise about general side effects. You're not going to go over everything possible. People get things from the pharmacy now that lists everything possible, and they may freak out. So you try to advise them ahead of time. The pharmacist will do counseling now, but not everybody wishes to receive the counseling. So getting them prepared for what would be normal, what would not be a normal reaction, what is something reportable, what is something to expect. Cultural considerations, modify communication to meet patient and family cultural practices. Interesting thing with patient cultural things, years ago as a registered nurse, I went on a medical mission in Guatemala, and we went way down the river and into very, very remote areas, things that you didn't think about, which I discovered during the course of the week. One was telling them to take the medication with water. You give them a little baggie with these medications that were donated, give them a baggie, and they take it, and they were putting them under the pillowcase, not understanding these pills were supposed to be taken, swallowed with water. We had to start telling them to do that. Another was giving a suppository and not telling them to take it out of the aluminum wrapper. I heard that from someone else that had gone on a medical mission. So there are things, never make assumptions, always ask. They may have rituals, they may have practices that are normal, they have things that they don't want to take. Talk that out and find out if we need to change our plan of care. The nursing process again, assessment. Their vital signs, any relevant labs. Do we need to be looking at creatinine clearance? Do we need to look at their albumin level? Do we need to make sure the liver functions good? Don't assume that the provider is going to order the relevant labs. You are a patient advocate, the biggest job that you have. Question, ask, intervene if necessary. Just because something is ordered, just because they say to do it, mustn't make it correct. If they're incorrect and you carry out the order and it's still incorrect, you are just as liable as the person that prescribed it. Be a patient advocate. Okay, identify patients at high risk for reactions, looking at other medications they've had. Have they had a problem in the past with something related to it, possibly a cross-contamination, something like that, or cross-reaction, not contamination. Assess their ability to follow therapeutic regimen. Can they really do it? I went to a home once. The person was supposed to be doing his blood sugar checks and doing his insulin. His hands were so arthritic, fingers were totally bent and contracted. Provider did not seem to have an issue with asking the person what their sugars were running and ordering them insulin, and knowing darn well with those hands that person could not be doing AccuChecks nor self-administering insulin. Person lived alone, yet nobody saw fit to stop prescribing and ask them questions. Assess patient's learning needs. There's always something to teach. So if you can't come up with anything else on a care plan, there's always and forever some sort of knowledge deficit, something that needs to be taught. Interventions. Avoiding contact with inhalation preparations. Certain things they want you not be exposed to, how to dispose of their sharps, how to report drug errors immediately, how to record information such as the drug effectiveness. Do they need to keep a record of the pain? Do they need to keep a record of the sleep if they're taking something for that, or for their depression, for their mood, for their appetite? Do they need to be recording their blood sugars? Does it need to be before a meal, after meal, 30 minutes after meal, before and after? And evaluation, identify effectiveness of medication, expected time frame. If it's a medication that's going to take 3 or 4 weeks before they get therapeutic effect, let them know it's going to be that long before they're going to really notice a difference. And don't just stop taking the medication without seeking some information or speaking with the prescriber. Where are we? Nursing diagnosis. These are some very common. You want to remember these common nursing diagnosis you can use related to medication therapy, any type of drug therapy. Non-compliance can be for multiple reasons related to whatever is appropriate for that person. Knowledge deficit related to whatever is appropriate. This can be an adverse reaction of a medication. And here, a hesitancy for fear of addiction, proper teaching about chronic pain or acute pain and how to take the medication, not to let the level get so high. All those factors are very important in your teaching. And of course, your planning, your API, assess, plan, intervene, evaluate, characterized by goal setting. The patient will independently administer a prescribed dose of albuterol by the end of the first session of instruction, or by the end of the second session. Patient will return demonstrate or something like that. And the qualities of effective goals. I use the term SMART. They do have to be patient-centered. It clearly states the expected change. It's acceptable both patient and nurse. It needs to be mutual, agreed upon, realistic, measurable, shared with other healthcare providers so everybody knows, realistic deadlines, identify components for evaluation. So SMART goals are specific, measurable, achievable, realistic, time frame. If you're able to answer those 5 things when you set up a goal, then you know you have set it up appropriately. SMART, specific, measurable, achievable, realistic, time. Your implementation, what the nurse is going to do to help assist or guide this patient to reach the goals that were mutually agreed upon. It's not your life, it's not your thing, and so just because that person doesn't want what you say they should want does not make them non-compliant. It needs to be geared for patient consideration, that you can mutually come to a place where you both agree, of what it is you hope to achieve. These are just general teaching for the patient, self-administration, or their dietary restrictions, avoidances, things to be included, what side effects should they expect, cultural and genetic considerations. Helpful and healthful points to remember. This is bringing us near the end of chapter 11. It's good to write things down for the patient, keep medication original labeled container, and store as instructed. If there's a visually impaired, may have them ask the pharmacy to write bigger on it. Write AM, write PM, write once a day, write something where they can see if they keep medication out of reach of children. If it's an elderly has young grandchildren or great-grandchildren around, keeping the medications out of their reach, because oftentimes you'll want to get to the not child-proof top so that they can get into their medications. Before using any over-the-counter, whether it's an aspirin or laxative, it doesn't matter, herbalist, something, pharmacy is a really good person to ask before taking it. Now, why are you taking each medication? There are lists that you can print off the computer, little booklets that a patient can have that can record all this for them. Alcohol interacts with many medications, affects the absorption, it may potentiate it, it may increase CNS, central nervous system, depression, so be very careful. There's some medications you cannot drink any alcohol with. Smoking tobacco alters absorption of some medications. It's important to see here. So that's the end of chapter 11. I don't think there's a patient-centered thing at chapter 11. No, there's not. So, safety and quality and pharmacotherapy. The pharmacy is incapable of making mistakes. People can get lax now that you have scanning systems. It's great that you have them. Unfortunately, the medication error rate has continued in spite of barriers to try to protect us from ourselves. Okay, right assessment, right documentation, right assessment. What are you thinking? Well, did you check their heart rate if that's appropriate? Are there certain labs you should look at before you administer the medication? Are you evaluating their pain level before you give this to them? Right documentation, name of the drug, the dose, the route. If you didn't document it, you didn't do it. Didn't document, didn't do it. Always record after their response to the medication. Right education, right evaluation. This is very important, the right to refuse. Everybody has the right to refuse care, but they need to be able to make an informed consent so they understand the decision they are making, so they can make an informed decision of whether or not they want to take this or refuse this medication. Five rights when administering medications. Right to a complete and clear order. I've been out of the hospital system for a while. I know I have a son that's a new registered nurse and working in a system where they have to read back, which I think is a great policy. Providers aren't real nice when if they get a telephone and they're getting an order over the telephone that they have to read it back. I know for years we used to do verbal orders, and verbal orders were done away with. If the provider is there, they can actually write the order themselves. St. Thomas, where my son works, has the providers actually put them in the computer system, but of course there's still those stubborn ones that refuse to do it and will write it, and it's not. And then you'll go in some community centers, like when you go for your mental health, and they still write things, and after a while you get pretty darn good at reading them. Right to have the correct drug route, form, dose, dispense, right to have access to information, right to have policies to guide safe medication. These are all your rights as a nurse. Right to administer medication safely and identify system problems, right to stop and be vigilant when administering medications, Never forget that, because you are that patient advocate. Okay. Again, in 2013 was more evaluations and things put into place. I just thought of it when I was doing this. I'm going to have to find it and upload it there. There's a really good documentary you should watch on medication safety. Oh God, it led into the development of numerous policies. I can't think of, I'm going blank right now. So let me get this lecture over. We're almost there, and I will find that and upload it on, because everybody needs to watch it. Proper disposal of medications. Do not flush drugs down the toilet unless specifically instructed. It's a different story when you have a septic system versus it going out into the normal plumbing too. And this is a really good way for discarding medications. Drug take-back programs. We're so rural out here, I'm not sure that there is any of those, but there is in the cities. I'm gonna back up one here. Okay, just notice at the end of chapter 12, there is a patient-centered collaborative care starting on page 129, and you have some wonderful boxes on page 131, guidelines for correct administration of medication, behaviors to avoid during medication administration. Those behaviors to avoid, really look at these, take these to heart. That's very, very important for safety. I was trying to find this in the text. Okay, I found it on page 130 at the end of chapter 12. The FDA pregnancy categories. Be very familiar with this. This is something any nurse needs to know. Not many things are category A. Often most commonly you'll see the B. No risk in animal studies. Well-controlled studies in pregnant women are not available. Because of the fetus, they cannot do that, but they don't believe there is a risk. Animal studies indicate a risk for the fetus, risk versus benefit of the drug. That's one of the things the provider has to do, is the risk-benefit ratio, and discuss it with the patient so the patient can make an informed consent on whether the risk is worth it. D is unlikely that they're going to give it. X, never, 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 never. Okay, so I was told by Ms. Harlan that you have completed drug administration last semester, so I put these slides in here. I'm not sure how much you get this semester in the lab, but you'll probably get more in the clinical settings. So I went ahead and put these in because you would never get too much of how to give certain medications. You have a whole chapter 13. We're also going to be doing the, what's the name of it? The new program, Swift River. Have to get together with Ms. Harlan and Ms. Martin and figure out how we're going to incorporate this. I don't know if she's going to do more of it in the lab. I hope to use some of it in the classroom because there's a whole pharmaceutical section. I may give you assignments to do at home. We may do some in the class, but that's something that I think is great for medications, med passes, to do as many med passes as possible because you can never do too many. Administer eye drops, gently pull down the skin below the eye, the conjunctival sac. You never let the dropper or anything touch inside the sac, and this finger's a little close. I think I'd be a little off. It almost looks like you're touching. Of course, you have gloves on. Wash your hands. Dry your hands well. Put the gloves on. Administer. Take the gloves off. Don't press hard in the eye. You just kind of here to hold onto it. To keep the medication. This is a picture with the ointment. 1/4 inch wide strip of ointment. It doesn't show the actual tube, but you don't let the tube touch. And also teaching patients if they have conjunctivitis or whatever, they have to do their drops and how to do them properly. Ear drops. Easy under A child 3 or younger, any infant up to the age of 3, it's down and back. Everyone else over 3 through adult, up and back. You can practice on yourself if you feel that you can kind of hear the air canal pop open when you pull it the right way. Nose drops and sprays. When you're giving nose drops, again, do not touch inside the NUR with the dropper itself. Have them, prior to doing it, have them blow their nose. You wash your hands, put on your gloves, have them tilt their head back, lean toward the side a little bit that you're administering the drop in. Angling. The sinus in an adult is more up out toward the outer aspect, just like when you spray, you're going to spray toward the outer aspect. The young child, up to probably about age 6, the sinuses are not developed. All they have is a little ethmoid that's on the bridge of the nose, so you want to aim toward the ethmoid sinus. Don't blow the nose right after administering either of these medications. If you notice with the nose drops, the head is tilted back. With the spray, the head is neutral. Back and toward the administration site, and this, the head is neutral. I found this picture on doing multi-dose inhalers with a spacer. You can do it without a spacer, you just lose a lot less with a spacer. They shake the medication. If they're not using a spacer, they can breathe out all the air of their lungs, put the spacer or the inhaler in their mouth, seal it tight, press it down. If they don't have a spacer, they should try to hold their breath. They take nice, deep, and slow, and usually wait a little bit. Intradermal, and that's like your PPD test with the bevel up. I said, I'm cutting through these. I'll find out when we're in class how much practice you've had, and hopefully getting into the maybe you'll get practice in the lab, but definitely this chapter is pretty good. There's all kinds of YouTubes, and I'll find out what needs you really need. This is intramuscular 9 degree, subcutaneous 45. It says you could do sub-Q 90 with the sub-Q needle, but 45 sounds better to me. Okay, let's see. These are sub-Q sites that can be used. Intramuscular, your landmarking, dorsogluteal, deltoid. Remember, the deltoid is a little triangle muscle. I've seen too many times that shots have been given down in this area. Landmark, hold your fingers to your landmark when you give an administration. Try to go in here. I landmark on those bones. Vastus lateralis, that is the most common one where you'll give an IM injection on a child. It's a nice big solid muscle. Z-track, I don't know that anybody's given any Z-track. It's not very common. I've given very few in my life. Sometimes I've done things even like Finnegan utilized the Z-track effect just to try to help with irritation. So when you pull the skin back, inject the medication, so pull the skin to one side, insert the needle, inject the medicine. When you withdraw the needle, the medicine ends up where, so this does not leak all the way through the tissue. You give that for things that are very irritating. What's iron? Iron, can't think of it. Iron is a common one that's given. Iron dextran it's a common one that you will have to do Z-track. It's more staining to the skin. But, always, when you're going to give anything that's irritating to the skin, drop your medicine and change the needle. If if there's not a policy against it wherever you are working, I was always in the habit of changing out that needle after I drew up medicines. I just felt like the less irritation, the better for anything. This is just needles, injections, how many inches, just a review, because I believe you went over this. Intravenous, I don't know if you guys have done that yet.